Hello and welcome to today's session. In today's session, I'm presenting on urinary incontinence. Yeah, involuntary urination. Okay, somebody is urinating when he or she is not willing to do it, not ready to do it. Okay, and our main muscle of concern is the pubococcygeal muscles. Okay, you can see how somebody is supporting the bladder, guys. So urinary incontinence is, we are saying, it's an uncontrollable passage of urine. You cannot stop it. It just comes out. It can be transient or permanent. Okay. So possibly it normally involves the large volumes of urine or scanty dribbling. Okay. It can be classified as SOT, stress incontinence, overflow incontinence, urge incontinence. Yeah. So that we're saying that stress incontinence, it's normally caused by sphincter dysfunction due to pelvic floor weakness. So symptoms will include involuntary leakage of urine upon effort or exertion, or upon sneezing or coughing. Yeah, jumping. Somebody will urinate. Okay. Number two is urge or overreactive bladder. And in overreactive bladder, we are saying it's caused by involuntary or uninhibited dextrosal contractions due to dextrosal muscle instability. Signs and symptoms will include involuntary leakage of the urine accompanied by or incompletely preceded by urgency. Mixed is a combination of bladder and urethral dysfunction causing stress and urge incontinence. Signs and symptoms will include involuntary leakage of urine associated with urgency and also with exertion, effort, sneezing, or coughing. Overflow incontinence. This is we have a contractile dextrosa, and is normally associated by diabetic nephropathy. So you find that the signs and symptoms will have palpable or percussible bladder, large post-void residual capacity, diminished functional capacity with frequency. Lastly, we have continuous incontinence, and this one is normally caused by the vesicovaginal fistula, especially a complication in obs-gyne. Yeah, we have constant leakage of urine, and there's no desire to void. Okay. History. We are saying that you need to ask about the onset of incontinence, and for a description of the incontinence pattern, you obtain a description of normal urinary pattern and fluid intake. Okay. You inquire about other urinary problems. They could be hesitancy, urination frequency, urgency, nocturia, dysuria, and decreased force or interruption of urine stream. You need also to ask about the history of urinary tract infection, guys. Okay, urinary tract infections are implicated in urinary incontinence. Yes. Prostate conditions, spinal injury or tumor, stroke, yeah, cardiopulmonary diseases, chronic coughs, diabetes, obesity, or surgery involving the bladder, prostate, or pelvic floor. Yeah. Remember, we normally have damage to the ureter that normally leads to some temporal incontinence. Yeah. Great. So ask a female patient about number of pregnancies and childbirths. This could be contributing to continuous incontinence. Ask about smoking, alcohol, and caffeine. These are normally stimulants. They stimulate, or irritants. They irritate the bladder, yeah, causing the incontinence. Remember to get a complete drug history, because there are some drugs that have been implicated that cause incontinence. On physical assessment, doing the inspection, palpation, percussion, auscultation techniques, And here you're saying that you have the patient empty the bladder, then you inspect the urethral meatus for inflammation or defect, could be redness, painful, yeah. Have the female client bear down and note any urine leakage, yeah. Gently palpate the abdomen for bladder distension. Perform a complete neurological assessment, noting the motor and sensory function and obvious muscle atrophy. Remember that urine accumulation of waste could possibly lead to neurological changes due to accumulation of new ammonia, okay? Assess post-void residual urine using a straight catheter to fully drain the bladder. Causes, we have medical causes, surgical causes, and medication causes. Starting with the first one, benign prostatic hyperplasia. We're saying that there's an overflow incontinence resulting from urethral obstruction and urine retention. So, reduced caliber and force of the urine stream, urinary hesitancy, and a feeling of incomplete voiding constitute prostatisms and are the early sign of BPH. Okay, so urination becomes more frequent with nocturia and possibly hematuria as the obstruction increases. Examination will reveal bladder distension and an enlarged prostate. Okay, great. What about bladder stones? In bladder stones, we are saying that overflow incontinence may occur if the stones lodge in the bladder neck. Okay, so other findings may include of those of irritable bladder, such as urinary frequency, urgency, dysuria, hematuria, and suprapubic pain from the bladder spasms. Pelvic pain and pain referred to the tip of the penis, vulva, or lower back may also occur. Another medical causes is bladder cancer, and you're saying that urge incontinence and hematuria are normally the early signs of bladder cancer. So, obstructions by a tumor may produce overflow incontinence. Other findings include frequency, dysuria, nocturia, dribbling, and suprapubic pain from bladder spasms after voiding. A mass may be palpable on by manual examination. Diabetic nephropathy is another medical condition, and you're saying that bladder distensions with overflow incontinence may occur. Related findings include episodic constipation or diarrhea, which is normally nocturnal. We also have impotence. We also have retrograde ejaculation, orthostatic hypotension, syncope, and dysphagia. Guillain-Barré syndrome, multiple sclerosis are other degenerative conditions that could play a role in the medical conditions leading to urinary incontinence. So on Guillain-Barré syndrome, GBS, urinary incontinence may occur early in the disease process. The classic presentation of GBS is you have profound muscle weakness, which typically starts in the legs and extends to the arms and facial nerves in 24 to 72 hours. Other findings include paresthesia, dysphagia, nasal speech. Also have dysphagia, orthostatic hypotension, fecal incontinence, diaphoresis, drooling, and tachycardia. Okay. What about multiple sclerosis? Urinary incontinence, urgency and frequency are the common urological findings. Early findings include vision problems. Okay, so whereas this one is ascending, this one is descending. So multiple sclerosis is descending. Guys, you can check on my video and find out the main differences between Guillain-Barré syndrome and multiple sclerosis. So a pop will be coming up. Please click on it and find more about the two. Next, we have prostate cancer, and here we are saying that you have urinary incontinence appears only in the advanced stages. So urinary incontinence is possible side effect following radical prostatectomy. Other late signs include urinary frequency, hesitancy, nocturia, dysuria, bladder distension, pineal pain, constipation, and a hard and irregular shaped nodular prostate. What about the chronic prostatitis, inflammation of the prostate? Urinary incontinence may occur as a result of urinary frequency and urgency, dysuria, hematuria, bladder distension, persistent urethral discharge, dull perineal pain, and this may indicate, may radiate, also have ejaculatory pain, and sometimes decreased libido. Spinal cord injury is another cause, along with stroke or cerebrovascular accident. And they're saying that in spinal cord injury, we have overflow incontinence that normally follows rapid bladder distension. Other findings include paraplegia, sexual dysfunction, sensory loss, muscle atrophy, anhidrosis, and loss of reflexes far from the injury. On stroke side, yeah, we're saying that you could have either transient or permanent urinary incontinence. Related findings also include we have impaired mental status, emotional lability, behavioral changes, altered level of consciousness, and seizures. We also may have headache, patients with headache, vomiting, vision deficits, and decreased visual acuity. Sensory motor findings could include contralateral hemiplegia, dysphagia, ataxia, apraxia, agnosia, aphasia, and unilateral sensory loss. Urethral stricture is also a major contributor to urine incontinence. Okay, so we could have urinomas or urosepsis that may occur and block, okay, resulting into incontinence. Urinary tract infection can also contribute to urine incontinence. So we have bladder spasms or a feeling of burning during urination. Apart from those medical causes, we also have surgery, and we had said that surgery, urinary incontinence after prostatectomy may also occur as a result of urethral sphincter damage. Okay, so this is a common finding, especially in these patients who have undergone this kind of operation. What about drugs that can contribute to incontinence? You're saying that you have anticholinergics, skeletal muscle relaxants, alcohol, the TCS, antidepressants, antipsychotics, antiarrhythmias, antimuscarinics, antihistamines, angiotensin converting enzyme inhibitors all decrease contractility of the bladder and contribute to urine incontinence. Estrogen have also been implicated because they can cause increased urine incontinence. We also have the consumption of alcohol and caffeine can contribute to urinary incontinence. What are the nursing considerations? You need to obtain a urine specimen